everything that has to do with female veterans. I serve as a patient advocate for veterans who are having trouble getting into our system. I do a lot of training for staff. We do new employee orientation training, educating veterans on the fact that we do care for women, even though our women veterans are 10 to 20% of our population. I also focus on our quality metrics. So I'm very involved in the quality side of the house to make sure that our breast cancer screening metrics and cervical cancer screening metrics are above par and continue to remain that way. Additionally, we recently have started hosting focus groups across our healthcare system to try to identify specifically from our veterans how they feel about their services, what gaps do they feel like are there. I know myself, I'm not a female veteran. I don't receive care at our site. So that's kind of a way for us to hear specifically from our veterans what they want and try to take that back to see how we can achieve those goals. We also do a lot of outreach. We recently hosted, we just hired a new maternity care coordinator. And so we've been hosting baby showers and then and other educational events and outreach events. And I would say, as far as outreach, I would say that's one of our biggest challenges is trying to educate not just our providers and staff, but also veterans about what services are available for women veterans within VA. Our program is expanding tremendously. Even in the 5 years that I've been in the role, we've added so many services and benefits for veterans. So I would be happy to get some feedback on ways that we could get that information out to veterans, because every outreach event I attend, there's someone that I encounter who has no clue that we even care for women or about the services that we provide or that might be available to them.
Awesome. Jamie, do you have like a one-pager on those services that we could start to circulate? And I put that out to all three of our panelists. I mean, because we always do a follow-up email afterwards that we could attach to the email.
I don't have a one. Well, let me think about it. I know I have individual brochures on all kinds of different services. I do have a general services brochure that kind of encompasses it, but it leaves out a few things like IVF and infertility, and which I think is huge. We have we're having a lot more consults for that. And that actually leads me to one of my questions is, I see on the chat box, there's a little icon. Can we add documents to this chat? Because I do have a couple of things that I'd like to add.
I think you can. I think you can click on the, or
I'll try to upload.
Okay, perfect.
Okay.
And if not, send them to Emily and we'll send them out to the bigger Vmfa group, the whole group. Okay, that's great to know that you guys have all these services. Sharjuan, would you like to go next?
Sorry about that. I always have an issue coming off mute for some particular reason. But we're with the Stephen A. Cohen Military Family Clinic, like I said, here in Fayetteville, and we provide mental health treatment for post 9/11 veterans, family members, National Guards, Reserve, anyone basically who have served in the military just one day. They are, they can receive our treatment. One of the biggest things about our clinic is we like to say we allow the veterans or the military person to define who their family is. And that could be parents, grandparents, cousins, siblings. And that's a big deal because of the fact that we know that as military, a lot of the times our families are brought in to be able to help and assist when a service member has deployed and a spouse is working and may need that extra assistance. So for instance, you have a grandmother or someone in the house and they're experiencing things like anxiety, depression, insomnia, we can see that person too, by virtue of them being connected to the military. So we like to always put that out. We, like I say, we, for all kinds of mental health treatment, one of the newest things that we're doing now is PCIT training, which is parent child interaction therapy. And I know it's a pretty big deal starting out in a lot of places where we get a chance to bring in the parents to interact with their child and be able to assist them with things that they can say or how they can kind of assist their child with behavior issues. Because a lot of the times when they're seeing clinicians and they go home, the parents need that actual training too, to be able to carry on what the kid is learning. As well, we offer family, group, and individual counseling. Again, we see active duty service members now, but they have to, of course, have a TRICARE referral. We work very close with the WOMAC here. And because the Army has had this big push to where they cannot provide treatment a lot of the times on the basis within the 15 to 21 days, they're doing more of a push to get involved with outside agencies. And we're really happy to be a resource for the Fort Bragg area. In actuality, our catchment area is the entire state of North Carolina, as well as South Carolina. But I say that, but we do have 22 clinics around the US. And when I do my brief, I like to brief about all those clinics because of the fact that you all in the VA are going to see service members, veterans, families from all over. They're going to leave and they're going to go to another state. They may go to Alaska, Hawaii, wherever have you. So we have clinics in all of those states. Mr. Stephen Cohen, a lot of people know him from owning the New York Mets. He basically started this mission to serve the veterans, to make that promise to the families that he would take care of all of their needs because of his son. He was in the Marines. And when his son came back, he said, "Dad, this is what you need to do with your money." And he did. He made a commitment within 5 years to open 25 clinics. And we're at 22 right now. We started in the clinics started opening in 2016. So that's really good. So again, we have all of our clinics are around military bases. We have a high military cultural competency because everyone that works in our clinic is connected somehow. For instance, I just retired from the military, 27 years active duty. So I retired last year. Well, I feel like I know the community. I can go out and speak that part. I am a Blue Star mom. My daughter joined the military while I went to Afghanistan. My husband and I served side by side 23 years. So I was a military spouse. So again, our clinicians, they were military kiddos themselves, raised in military homes. We have spouses whose husbands are deployed. All of these clinicians, we have Spanish-speaking clinicians, Black, white, Asian, and we try to make sure that we run the gamut. We have a male as well. So we try to reach the community and try to provide all their needs. We're confidential, low to no cost. Mr. Cohen has set aside a grant to assure that we don't turn anyone away, because as we all know, it's hard to get that veteran and military family member sometimes through the door. And when you get them through the door, you don't want finances to be something that pushes them away. So there's a grant. It used to be briefed that our clinics are free. We're not allowed to do that, of course, because of other healthcare facilities and things like that out there. So we have to give them an opportunity. So we ask anyone if they have insurance. If they can't use that insurance, don't want to use that insurance, we don't ask any questions. We try to see if they can qualify for that grant most of the time that they do, because he likes to have no barriers. As well, we are virtual and in person. The great thing about us being in person is that I've now partnered with the Armed Services YMCA on Fort Bragg. They come and provide free childcare if someone wants to be seen in clinic in our actual facility. That's absolutely amazing, because of course, you know, the Armed Services YMCA on any base, they are strictly for the military population, not a regular YMCA off base. So being that we only serve the population of military and veterans, they were able to, for the first time ever, extend their services off base. So we're extremely happy to provide that service. As well, we just hired a new clinician that is out in Charlotte. That is due to our partnership with Veterans Bridge Home and Paul Berry and Al Lampkins here. We gave them a place to sit when they come to our clinic, no questions asked. And, you know, sometimes doing that starts another partnership that you didn't know was going to be there. And they have invited us to be able to use space in their clinic in Charlotte, to which we were able to hire an in-person clinician. As well, I know I have a lot to say, but we have very short wait times. And I say that because we grow according to the need. A lot of the times there's a set amount of clinicians that are supposed to be in certain areas or places. If Fort Bragg is going through something, there's a deployment and we are getting to the point to where our access to care is at 6 weeks, that's unacceptable to us. We do have a way that we go ahead and get our clinicians vetted, through the process way beforehand, and when the need is there. So we don't like to turn anyone away. Again, we can get anyone intaked into our clinics within 24 to 48 hours. And that is with the intake provider. Depending on what the service member or veteran says, I only want to come to the clinic at night, or I only want to come on Fridays, we can usually get them typically in within 1 to 2 weeks. For the first time being with their clinician. But again, it always depends on the request of the service member. So you may have a service member says, well, I went to the Cohen clinic and they told me it's going to be 4 weeks. Well, that was because he could only be seen on a Thursday at 5 o'clock. So there's just some things about that as well. And lastly, I want to say that we do have case management services, wraparound services. So whenever we provide the 8 to 10 sessions of outpatient care in our clinic, we don't let the veteran or service member go. We call them at the 30-day mark when they have finished with the treatment in our facility. We call them at the 3-month mark, the 6-month mark. And then we also reach out to them at a year and see if there's anything that we can do for them. Again, we are in with NC Works, NC Serves, and a lot of other organizations where we can assist with those veterans getting the help they need. And if they feel they need to come back to our clinic, we can get them back in as well. I'll leave it at that. If you have any questions for me, please let me know.
Yes, I have questions, so I'll circle back. I'll have Laura go next but we'll definitely come back to questions, okay? Laura, I would love for you to talk about how your role plays a part in veterans healthcare.
Sure. So in suicide prevention, we do a lot of outreach. Like Jamie was saying, outreach is really important to be able to get out in the community, speak with veterans face-to-face with their family members, let them know about VA services and how to get enrolled in VA services. Because we know that being enrolled in VA services and having that support is actually a protective factor with when we're talking about suicide risk. So we want to make sure that those veterans are getting the support that they need, that their family members also have that support available and know the resources available to them. So definitely outreach is a huge part of what I do. We also manage a list of veterans that are considered to be at high risk for suicide. Many of these veterans have had recent hospitalizations or maybe had an attempt. And so we will track them and place a high risk flag on their electronic record. So that way, if they're seen by a provider, then that provider is alerted that this veteran is at acute risk, and to make sure that they're asking appropriate questions and making sure that that veteran is getting all of the services that they need and the support that they need to get them through that acute risk time. Those flags get reviewed every 90 days. So we review them, we see, are they attending their mental health appointments? Do they have a support system, a network in place that can help them? Do they have a safety plan in place that they can turn to? Are they aware of the emergency resources? And then we determine if that flag is going to be continued and they need continued case management with us, or if we can go ahead and discontinue the flag. After a flag is discontinued, we still send outreach letters to the veteran each month for the next year. So they do get kind of just caring communication is what we call it. Just a little letter to check in and say hello and wish them well and let them know that we're still here if they need us. The other part of our large part of our program is responding to veterans crisis line calls. So I think a lot of people don't realize when you call the Veterans and Military Crisis Line, the 988 number, veterans are given an option to be able to speak with someone locally. So you don't just get someone at the national level to talk to. You can also speak with someone locally and they'll refer that veteran to us and let us know that they called. And that way we can follow up with them. So our case managers will give a call. Typically it's the next day, and talk with the veteran to see if there's any additional services that we can help them get connected to or get into place. Really, we're very focused on getting veterans connected to care, whether that be through VA or community resources, just meeting the needs that they have at the time. With suicide prevention, it's not always about mental health. I think that's a common mistake that people make, and in thinking, oh, it's just, they need PTSD treatment, they need mental health. A lot of times it's those social determinants of health that are key factors. We're looking at if they're homeless, if they had food insecurities, relationship issues. There's so much that goes into it that these veterans really need a holistic approach to their care. So we try and focus on what the needs are and how we can help meet those needs and get them connected to have those needs met.
Awesome. Thank you. So bear with me as I ask this question, because I'm probably going to completely show how much I don't know about all of this. Because we always have someone here from the National Guard. Does the National Guard qualify for any of these services, the reserves? Is it just veterans and families? Like because we work a lot with the Guard, so I want, oh, good, thank you. That was a good question. So who would like to go first? Sharjuan, I saw you kind of smiling, yes?
Oh, yeah, that was the first thing I said, because a lot of the times National Guard and Reserves get left out.
Oh,
They get left out. We make sure we state that whenever I say it, yes, ma'am, and their families too. And then also with National Guard, I will say, a lot of times Reserve and National Guard, they're on or off, active duty. So when they're not on active duty, we don't consider them active duty, so they don't need a TRICARE referral.
Okay.
And their families don't anyway. So I want to make sure that, y'all know that.
Awesome, thank you.
I'm going to defer my answer to Shelton.
Come on.
Shelton works with a Guard like all the time, so I'm going to defer. And I am like not an eligibility specialist. There's certain, you have to know your strengths, and that is not mine. So.
Thank you. No, our National Guard is really different and diverse because most of them are not your traditional guardsmen. We have some that are considered active Guard Reserve, AGR, which are on an active duty status, which is a Title 32. It's a little bit different than your traditional active military, which is on a Title 10 status, a federal status. The question of are they eligible for the services is it's a yes and no question, to be honest with you, based on their criteria of how long based on that criteria of if they deployed or not, and then how long ago did they deploy? Is this something that happened while they were in service, even if it's a weekend service or not? There are so many different criteria for Guard and Reserves that it's you can't just pinpoint if a particular person is eligible or not. According to eligibility, you have to have 2 years of continuous active military service or have been on an active status in a combat zone to be eligible for VA care. But again, there are caveats to that. And so based on those different caveats depends and determines if a person is eligible for care. I say this, if you served and you're having any type of medical issue, crisis, or what have you, go to the VA and let them tell you that after they treat you, because they're not gonna turn you away, but they're determined about additional services later. And if they do not, if it's not available for you, then they will provide you resources in the community for them.
If I could piggyback off Shelton, this is Matt, I'm a retired guardsman from North Carolina. And because of the eligibility issues, many guard states like North Carolina have their own suicide prevention
Yeah.
and awareness, have women's health experts, have psychologists, have clinicians. We have an entire behavioral health section.
Stephanie.
So, yeah, Stephanie Nissen. So because sometimes these guardsmen are left behind because they might have been deployed, but they've got problems and issues that need to be addressed so they can continue to serve. So they stood up these sections. So luckily, North Carolina tries to fill in all the gaps where maybe the service member isn't eligible for the VA.
And I will say that the National Guard works very closely with the Durham VA in particular. I'm not sure about the Fayetteville, Salisbury, and the Asheville, but Durham VA, they work very closely with our team on an individual basis, as well as collectively to see and make sure that their guardsmen are taken care of.
Awesome, thank you. Before I move on, does anyone else have questions with anything we've talked about? No, okay. I know Sharjuan touched on this about how long it takes for a veteran to be served. You said 1 to 2 days. Jamie, what kind of is an average for a female veteran to get service within the Women's Health Department?
So I think there's a couple.
That a loaded question. That's a loaded.
That's fine.
Depends on what they need to be seen.
Yeah. Exactly. That was what I was actually going to touch on. I would say that our primary care metrics right now, I think our goal is less than 20 days, but by the time that they call for an appointment, and we're meeting those metrics. We do have some, and I will say it depends on what they're coming in for, and then it also depends on where they're at, because we do have just to be very honest, we have some space challenges and some provider challenges. So like down east, at our Greenville and our Moorhead clinic over the past couple of years, we've had trouble recruiting providers in those spaces. So we've relied a lot on telemedicine to treat patients and get them in. And then in Durham, we have some space challenges. So like in our women's health clinic, for example, we have 5 rooms in the women's health clinic, and within that space we service primary care, mental health, we have a pelvic floor physical therapy, we service mental health, we have our GYN team and our breast team all co-located in those 5 rooms. So it is literally a puzzle to figure out who's there that day, and staffing and things like that. So space is definitely something that comes up pretty frequently when we report to leadership and leadership locally, leadership nationally. Our program is growing exponentially. We have like a 34% growth of women veterans every single year in our catchment area. And so, part of my role is to identify where that growth is, and how we're going to accommodate that growth in the future. I don't know if you're familiar with just VA projects in general, but it takes years to plan and develop and then actually build. And by the time we build, our numbers are kind of behind. So we actually are one of the facilities in Durham that are in the nation who's continuing to grow and expand and build spaces. So we've broke ground, I believe, on a new location in the Garner area, because we've identified that Wake County area is one of our fastest growing populations for veterans in general. But that's going to be an outpatient services center. And it will have a women's health specific clinic. And the goal is to have radiology services there, so they don't have to come to Durham, because right now at our Raleigh clinics, they're having, anytime you need radiology services, you're still having to come to Durham for that. So really trying, I think overall the VA's mission is to, bring our care to where our veterans are and try to really limit them having to come to us in one specific location. But yeah, I think, as far as wait times, we're trying to get patients in as urgently as possible. So specialty clinics definitely get our patients in quicker. We've hired a lot of staff. We recently hired a breast surgeon for our breast clinic. We've added additional gynecologists in our Durham space, and we have an additional GYN in our Greenville space. So, and we are working to hopefully try to get a pelvic floor therapist down in Greenville, but that's one of the things that those focus groups have really identified, because it's one thing for me to sit in a meeting with executive leadership and tell them things that I see that I think, could benefit our veterans, but hearing specifically from the voices of our veterans of, most of our services are in Durham. They're having to be sent out for care in the Eastern market to care in the community. And a lot of our veterans struggle with getting appointments, and just east of 95, it's hard to get Optum network providers. So that's another aspect of care that we're working on, is trying to reduce the utilization of care in the community and really bring our veterans back in-house for care with providers that have been trained to care for veterans, quite honestly.
Thank you. Laura, do you have something to add to this? I mean, I have to believe that if someone is a high risk for suicide, they're going to be seen very quickly. But I mean, what if someone isn't necessarily high risk? I mean, what would be kind of the process? What would be, the length of time for them to get connected to services?
Yeah, so basically in suicide prevention, we don't provide any direct care. So we're not actually the ones providing the mental health service. What we do is we would follow up with those crisis line calls. So if a veteran is calling and they want to get connected to care, we would follow up with that veteran and put in mental health consults. And then it would kind of go through the chain of command at VA, and the appropriate clinic would be alerted to get that person scheduled. They typically call the veteran within a few days. It's typically 3 or 4 days, and that veteran will be contacted to schedule. As far as scheduling for mental health, I don't know how long of a wait that would be to get them in. But typically the phone calls that we're getting are veterans that are already connected to care. So it's a challenging question for me to answer, like starting from the beginning, because we don't typically get calls from veterans that are brand new to VA and are not connected to anyone. It's typically veterans that are already connected to a provider. And then we certainly can alert their provider that they called the crisis line and what the situation is. And we also document the phone calls to the crisis line in their electronic health record. So that way their provider is alerted to what the phone call was with the crisis line as well. Because it'll say like what the responder talked about with the veteran and what their plan was. If it's an emergency situation, then the responder would contact like local police to go out and do a welfare check and possibly get the veteran to either a local hospital or to come into the VA to be seen right away. So definitely if it's like an urgent or an emergency situation, then they would be seen right away and there would be no delay in care at all. It would be an emergency service. For something that's more routine, it might be a few days before they're connected to someone in mental health for an appointment.
Okay. And this kind of leads me into my next question, because just by the nature of how we all interact, because we see each other at events, you know, these kinds of meetings. So a big part of, like, when we're working with a veteran, what I would typically do is, I mean, I've done this many times where I've called Laura and I've said, I've got a veteran not doing well. What can I do? How should I handle this? So you kind of went through what the process would look like, but I would like to hear from both Jamie and Sharjuan, like, what is the process of referring them to you? Because now that, you know, I mean, I have these relationships with you, I believe in the soft handoff. I want to know that when I'm referring one of our veterans to you, that, and just by the nature of our relationships, I know that they're going to get that customer service, if you will. So, but is there a different approach that we should take, or is it okay if we continue that I reach out to you directly? But if there is something different that you would like us to do, please share that so that we kind of all have a general understanding.
I know for the Cohen Clinic, we will accept any kind of way you would like to get the service member to us. For one, people call me, especially on the weekends, and I directly connect to the director and say, hey, we have a crisis patient, let's get them in immediately. Or they can simply call the front desk. Our lines are manned 24 hours a day, 7 days a week. And we also have, of course, we have other clinics, of course, that are seeing service members and families virtually as well. But if you bring them into our clinic, if they needed a TRICARE referral or anything like that, we can go in the system. I wanted to say that, and we can help find that authorization if it's there. If they don't need it, we don't worry about that. But again, call, email, fax, anything of the sort. Even if you just have a name or a number you want us to reach out to them, we will call them. We have our directors, assistant directors, reach out to the veteran, just to kind of talk to them, kind of smooth it over and find out exactly what their needs are, and kind of give them that warm and fuzzy to get them through the door. We actually have some people here we like to send out and be able to help meet the veteran. A lot of the times these veterans, they are afraid to simply come into a facility. So you have to meet them where they are sometimes. And that's a lot of what I do as well. So again, it's pretty much no one way to do it. It's however you can get it done or you need us to do it.
Jamie, do you have a different response to that question, or?
Yeah,
do you have
absolutely. So I'm actually uploading into the chat. National Women's Health Services has put together Women Veteran Call Center. And so that is a call center that's managed in DC. But it's managed by women veterans. So when the veteran calls, that's who they'll speak to. They don't have access to CPRS, but what's really nice about this is no matter what the patient is calling for, whether it's, I need help with my ortho appointment, I need mental health services, I've never been to VA, and how do I get connected? So the call center, when a patient calls, they can call or text that. They take down the information, and then what they do is they take their address and phone number and all their information with a general message of what they're calling about, and then they locate the closest VA that they're affiliated with, and then they send a message, an email to the Women Veteran Program Manager that is affiliated with the location where that patient should be connected with. And as the Women Veteran Program Manager, we have 3 business days to respond to that, to call the patient, to get them connected, to help them in any way to answer the question they have. What's nice about that is not only am I on that email, but also our VISN lead is on that email. So if I'm out, somebody's catching that. And then usually on my email, I'll have an away message. So if I'm away, our assistant women veteran program manager will get that message. So it's not just like a one-stop shop where, you know, if you need something and you're trying to get in touch with me and the only person you know is me, it doesn't really stop there. So that's what I generally tell people, is to utilize that women veteran call center. The other part of that is we are, they generate reports every month, and tell us how we're doing on our 3 days. You know, if we respond within 1 day, we get a higher percentage, whatever. But The other thing is if I drop the ball and it's something I saw and I got, busy doing something else, or I tried to call the veteran and they didn't respond and I didn't respond, like, our responsibility is to respond back to that email with the intervention that we did. And if I, for some reason, don't respond to that, they send me an email back as a reminder saying, hey, did you reach out to this veteran? The veteran still hasn't heard anything. So there's kind of some checks and balances there to make sure that the veteran got the information that they needed or the help that they needed.
Thank you.
And I put the brochure, it's like a poster in the chat box for that too, with the information on it.
Thank you very much. Do any of our panelists have anything else that they would like to add? Do we have anyone who's in the meeting who would like to ask a question?
I've got one real quick.
Yes.
Go ahead.
Does anyone have any objections if you send out a follow-up email that we get your point of contact information and email address? Is that okay?
Yeah. Are
Because
you okay with that?
really good stuff I'll definitely use when I'm talking to guardsmen and reservists across the state. Thank you.
Gotcha.
The only thing I will just add is I entered into the chat and I'm going to send Emily some additional brochures. National Women's Health Services went through this year and updated all of our brochures. So there's specific brochures on our infertility and IVF. There's specific brochures on our reproductive health. And there's just a laundry list of them. I was telling Emily privately, I don't want to clog up the chat with all of my information. But I would say my biggest takeaway would be it says WHTT, which is Women's Health Transition Training Participant Handbook. And that is a very generic, non-specific to Durham VA, but a very generic overview of the women's health program within VA, what it looks like, how a veteran transitions out of the military into VA, what our primary care teams look like, the fact that we have designated women's health providers, the fact that there's specialty women's health, mental health teams. And then it goes into it's a pretty large brochure, but it goes into all the different opportunities that are available for women in VA. So I would say if there's one brochure that you use, it would be that one. But then also they can contact me if they want more information about something specific, and I'll also include the other brochures that have more information. But if you were just going to use one, I would say that I found that to be very useful. It's probably one of the best things that I've ever seen come out of National Women's Health Services. So,
Wow, thank you. Yes.
And my question is actually for Ms. Burgos. You mentioned earlier about this PCTT, the parent-child PCIT. This training that you provide for between the patient or the parent and the child, is it specifically for those parents that are just reintegrating back into the family dynamic from a deployment, or are those just so that parents and children can just work together to start building a better cohesive relationship? And the reason I ask that is because I know our vet centers have group settings that they do for parents that are integrating back into their families' lives, and they'll have it where they have those family group settings to include the children, spouse, and what have you. So how is your program different from that one is what I'm asking.
So being that ours is new, and it might not necessarily be different. Right now, they're currently in Boston with this, with the PCIT. We start in January, our clinicians. So we'll be getting all the information that they're going to be bringing back. But essentially, our PCIT training is not just for those that are reintegrating. It's for any child adolescence issues that may be had, any behavioral health issues. We're talking children, well, right now they're determining the age, but we knew 5 and up. Because you can talk to those children, they can talk back. And then they are thinking about going all the way down to 3, just for the parents to be able to integrate and talk with the child. So we're getting more information. I just dropped our brand new flyer into the chat because we haven't even started. It starts in January. We do know that Womack Hospital is doing that, and we are very familiar with the vet center here in Fayetteville because we work with them real close. So it might not necessarily be different, but I can definitely get you the information on that from our director.
Thank you.
And we're currently putting in like all of the screens and TVs and things like that. We're going through a total transformation, which is awesome because, of course, with the earbuds, we have to be able to see into the rooms. And so it's a total transition. Very new. We didn't even know we were going to be doing this a few months ago. So it's awesome, but we will give you that information.
And my next question, I'm sorry.
No, you're fine.
Is I know you said that this is new and exciting, and I would really like to hear more about it. But how are you getting your information? How are you disseminating this to both the active duty, the National Guard, the reserves? How are you disseminating this information so that we, even in the VA, can actually help to promote it?
Right. So the new flyer I just sent you, we just got that. So we're actually not really disseminating the information yet until our clinicians return back next week. And they're going to tell us exactly how they would like to push and where we're going to start. So we don't have the actual dates yet, but of course it will be January. So when I get that go ahead, it's just like a new program. They're like, hold, and then go. But that's where we're at right now. So the only thing that I can really say is that PCIT training is starting as of the 1st of 2023, but we haven't talked too much about it.
Thank
So
you.
when we send the email, her contact information, maybe the two of you can connect, so she can let you know after the first of the year, go. And you can also communicate with us and we can hear it too.
I got you. Definitely. That's why I say we're excited about it, because of course we didn't know that we were going to get the grant and everything to be able to provide that here in our clinic. So that was the excitement there. We did have some interest from Womack, so we're waiting to brief them as well. So
Perfect.
Great. Any other questions from anyone? So I have one last question. This has nothing to do with the topic of today. But I started to record at the beginning of the meeting because we've had a lot of people ask. So we're actually thinking of doing a separate VMFA YouTube channel from all of our meetings so people can go back and get the information. I just wanted to ask everyone's permission that they're okay that I share this recording today.
I have to let my agent know.
I should have asked. So I'm so sorry, but if you're okay with that, I would really so much useful information that I want people to be able to understand and to learn.
Go there and.
Yeah.
Absolutely.
Okay. Thank you so much to our panelists. This was so wonderful. To our guests, thank you for joining us. And hopefully we'll see some of you in person next time. You can ask these gentlemen, lunch was amazing. Y'all missed out. So maybe next month, which our next meeting will be January 10th. So second Tuesday, and we're gonna have lunch. We're gonna start at 12:30 for the lunch and 1 o'clock for the hybrid meeting. So please let us know if you're able to attend, and the topic will be housing, veteran housing. So have a great holiday.
Thank you.
Thank you.
Bye,
Thank
everyone.
you.
Thank you.
Bye.